Okay, I'm going to go ahead and get going. I don't see people popping in, but people may be joining as we move along. So again, this is Bianca Frogner. I'm a professor at University of Washington. I'm the director of the Center for Health Workforce Studies, but I'm also part of the leadership team of the award network. It's so great to have everyone here today. We will be hearing from Megan Gately and Maureen O'Connor about video delivered dementia, home safety, and caregiver support. But before we go forward with their presentation, just a few housekeeping announcements. As always, you can find all the previously recorded webinars on the Award Network website. You can get there by the QR code. We also love to hear from you all about ideas of future webinars. We have a great webinar committee that helps us organize these, and we certainly are always looking for new ideas that you all want to hear about, because this is really for you all, that we want to make this useful for. So I'm trying to navigate to the next slide here. We do have an upcoming webinar in September on co-designing programs with long-term care residents and care partners. So please go ahead and sign up for that. And again, you can find all of our future webinars also on the website. We want to encourage people to save the date for Thursday, November 14th, 1 to 5 p.m. There will be the GSA meeting taking place in Seattle, and there will be an Award Network annual meeting taking place as part of that. So if you find yourself here in my hometown here of Seattle, we hope to see you there. I will certainly be there. So more details will be forthcoming, so please just keep an eye out for that. There's also a survey out that we have that we're trying to figure out how to get you all more involved. So keep an eye out for your newsletters. I think it was in the last newsletter. You could probably find the link for volunteering, but we do always want people in our network to be involved in our various committees. We have the Pilot Award, and you can be part of the review committee. We just had our Summer Institute, and there are ways to get involved in that. So we want to get as many people involved in the network as possible in activities that we have. So if at any point in time you're interested in volunteering, feel free to reach out to me, to Joanne Spetz, anyone on the leadership committee, or the webinar committee for that matter, and we can figure out how to get you more engaged. Also, I want to thank everyone who did attend the Summer Institute in San Francisco that just took place at the beginning of July. It was really a fantastic and a successful first Summer Institute. I had a chance to meet some of you all there, which was so much fun. And then we're going to do this again in a couple years in the summer of 2026. So if you missed out this year, don't worry, there's another opportunity to do it again in the future. So before we move on to our presentations, I do want to thank our wonderful webinar committee members who made this all happen. Megan Gately is one of our committee members and our speaker today, which is so fantastic. So this is just an example of how our webinar committee members get engaged. And also thank you to the leadership committee, including Joanne Spetz as the PI and the director of the Award Network, for everything they do to organize these events. And again, I do want to acknowledge NIA as our funder and the usual disclosures as written here. So with that, I'm going to introduce Megan Gately, who will then go ahead and be the MC for today. So Megan has her PhD as an occupational therapist. She's an occupational therapy health scientist at the VA Bedford Healthcare System's Geriatric Research, Education, and Clinical Center, or GREC. She's an assistant professor at the Boston University School of Medicine, Division of Geriatrics. Dr. Gately utilizes mixed methods to examine how innovative care strategies can reduce barriers to care, particularly for older rural patients with chronic conditions such as dementia, as well as their caregivers. So with that, I'm going to go ahead and turn things over to her and have her go ahead and introduce our additional speaker, Maureen, and they will both be speaking today. So thank you so much, Megan.
Thank you so much, Dr. Faulkner, and I'm going to share my slides. So if someone could give me a sort of a...
Looks good. Yes.
Looks good. Okay, great. Well, thank you so much for the kind introduction. As Dr. Faulkner said, I'm Megan Gately. I'm an OT and a researcher, and I'm excited to talk with you today I and my colleague, Dr. Maureen O'Connor, about video delivered dementia interventions, specifically home safety and caregiver support. So we have a few slides here, and then I'm going to introduce Maureen and turn it over to her. We have no disclosures. We both work for the federal government, but this work is all of our own. And just to set the stage, I don't think any of this is unknown information for this audience, but just to give a sense of what the landscape is that drives our work. We all know that we have an aging population. We've all seen the data and the projections. We know that older people want to age in place, but yet they do so in the presence of complex chronic conditions, including dementia. And so we have to figure out sort of how do we support them, where they live, and again, how do we help encourage them to stay at home. We also at the same time have a shortage of healthcare providers. Of course, we all know there are workforce challenges related to dementia care in particular, which can be exacerbated for patients being able to come in and their caregivers. So there's really been an attempt to reduce those barriers to care, and they can be rife, not just the regional barriers, but also issues related to health literacy and care management. So we did see a trend toward online services prior to the COVID pandemic, but it was obviously rapidly accelerated by COVID. And so telehealth, just to set a few key terms, broadly speaking, is the application of evaluative, consultative, preventative, and therapeutic services basically delivered through technology. So it's a range of services. It can be, again, having a first appointment with the patient. It can be follow-up. It could be diagnostics. It could really be a range of services. But basically, telehealth can fall into two broad buckets. So one would be asynchronous forms of telehealth. So these would be brief electronic consults between providers, store and forward, where you're sending sort of imaging, wounds, things like that, or remote patient monitoring, where you're having a patient send you asynchronously BP, glucose levels, and things like that. For synchronous, that's what we're going to be talking about today. This is basically where you're connected to a patient. You're in two places at two different places at the same time, connected by either video or phone. And so we're going to be talking today about the video telehealth aspect. And so telehealth for the VA, which is where Dr. O'Connor and I work, has been actually a part of our care for decades. The VA has really been a forerunner in telehealth because we have such a large integrated healthcare system. Many of our veterans are actually rural and they live far flung the medical centers. So we have a lot of veterans who get care at these community-based outpatient clinics, or that they get care dialed in from where they are. And so we have some infrastructure facets which have actually facilitated our use of telehealth, including we have telehealth clinician technicians. We have software that's been specific for us. We also have some infrastructure affordances that make it easier for us to do telehealth, in the fact that I can have a license in one state and deliver care across state lines due to federal supremacy. And so really the VA has been sort of ahead of the game in terms of using telehealth to deliver care to meet access challenges, again, long before COVID hit. But when COVID did hit, we also saw a massive upswing, in particular in VA Video Connect, which is our in-home video technology. As I mentioned, a lot of the VA care through telehealth has actually been between clinic locations, like a remote rural outpatient clinic dialing into an urban medical center. And you did a lot of phone telehealth services. But in terms of in-home video care, that really just ramped up during the COVID pandemic, not surprisingly. And just to give a sense of sort of like the interface between technology and certain patients, we have some digital divide issues, which we noted during the COVID pandemic, which are related to age. Some of it is driven by some biases against older patients, but we do see in general that older people are using technology more. You see some great data here from Pew Research about how older adults increasingly own smartphones. They go online, they use social media, but we do see sort of a drop off in technology utilization when you get into the older age bands. And so when we think about dementia and how the number one risk factor for dementia is advanced age, when we see people who are in the upper regions of their age group, we do find that the technology may be a bit more of a challenge for them. And then we kind of layer on top of that the functional implications of dementia. And so obviously everyone here is familiar with the etiology of dementia and the course in general. But what I just want to highlight is sort of how the complexity of a video telehealth session can really be complicated for someone who has cognitive impairments, even mild cognitive impairments. So declines in judgment, new learning, orientation, all of those things can really affect someone's ability to engage in a video session. And so we'll talk, Dr. O'Connor and I, a lot about partnering with caregivers, particularly around the technology, which can be complex. I mean, those of us who Zoom all day, we know how to turn our cameras on and activate our microphones, but as we even saw demonstrated this morning, there can be challenges, and then you really need to be able to adapt and kind of think on the fly often with technology in general. So thinking about how does someone with dementia navigate those challenges when they are complex. So what can be done over telehealth in the context of dementia? So there's actually quite a bit, and Dr. O'Connor and I and others in our group have been looking at sort of telehealth for dementia for several years. But today we're going to zero in on just a couple of particular areas of clinical practice. One is in the realm of dementia home safety, and then Dr. O'Connor is going to talk a lot about caregiver support. So why telehealth for dementia? So first I want to just sort of present some qualitative data from one of my projects that really, I think, sets the stage for why we should be thinking about telehealth for patients with dementia and their caregivers. So I had a study in which I interviewed caregivers of veterans with dementia who lived in an outpatient setting. And I wanted to kind of get a sense of what is their experience of the care system to try to see where telehealth fits in. Whether they'd be open to it, how it might be beneficial to them. So I interviewed 24 middle and older age, mostly spousal caregivers of veterans, because we have a mostly male veteran population. So a lot of our caregivers are actually female spouses. And what we found in talking to these family members was that the interaction with the healthcare system is actually quite complex, and it extends well beyond the actual the visit with the clinician. So people talked in great detail about how even preparing for the visit can be really fraught. Some people said that they told the patient the day before, oh, we have an appointment, we're going to the doctor tomorrow, and then he would just be anxious for hours. Some people said, oh, he woke up in the middle of the night and he got dressed and he was waiting at 3 a.m. to go to the doctor. He knew he needed to go, but he was just sort of confused. So the anxiety and the cognitive challenges can really make that whole sort of preparatory phase very challenging for both the person with dementia and the caregiver at times. Then there's the concept of getting to the medical center. And so they talked in great detail about it's not just sort of the drive, which often involves coming into the city, parking, navigating into a clinic where they maybe haven't been or they don't go very often. It's also, again, layering on all those cognitive challenges, the short-term memory issues, not knowing, like, where are we going? We're going to the doctor. Why are we going to the doctor? And sometimes the behavioral concerns, which can be prompted by that anxiety. People with dementia also, because they are older, often have mobility challenges. So again, we often have caregivers who described like it was really tough getting him into the car, or even getting him dressed and ready to go is just under this time pressured circumstances can be really challenging. And then they described actually coming into the clinic. And so by the time they go through all of that, then they arrive in front of the clinician who maybe isn't getting as accurate a picture of the person with dementia's function than they may have otherwise. And so all of this sort of just, I think, provides a nice kind of rationale for how telehealth can be so helpful to families. So I'm going to talk for a few minutes just about sort of how we have run projects looking at how to do specific types of OT interventions over telehealth. And just specifically, we did a home safety evaluation with veterans with dementia and their caregivers. So we had a pilot in which we worked with mostly caregivers since we needed them to do the technology for us. And so we had caregivers of outpatient veterans with dementia who each received 2 types of home safety evaluations, which were conducted by occupational therapy trainees under my supervision. So just to give you a sense for those of you who may not have had, or maybe non-clinicians, or maybe haven't had a home eval. So what we typically do when we do a home safety evaluation is I or the clinician goes into the person's home, obviously. I might often bring a standardized checklist, and I interview the patient or the caregiver to try to get a sense of what their day-to-day function is, where they're having difficulties. And then I assess as much of the home environment as possible, wherever the person needs or wants to go. So this includes exits, basements, if they need to go into the basement. And I'm really looking for any notable safety concerns, often around mobility. In the context of dementia, we're looking for often different kinds of concerns. So if the person, for example, is accessing the kitchen and they're leaving the pot on the stove, I may be looking particularly at like, well, does the stove have a safety shut off? Or can we remove maybe the medications if the person's having difficulty with accessing medications or taking them out of the regimented schedule. So I'm walking around the home, I'm observing, I'm smelling, I'm seeing, I'm hearing, all of that. So think about, and then often taking measurements as well, particularly when it comes to if I want to provide a grab bar, or I'm thinking about, does this space allow for a wheelchair if the veteran needs a wheelchair one day? So I'm often taking measurements. So if you think about that kind of complex evaluation process, how would we translate that over video? So again, in this pilot, caregivers got and veterans got one traditional evaluation where the OT went into the home under my supervision. And then they received a video. So again, a second OT blinded to the first OT's findings, went in and did a fully telehealth evaluation. So in this instance, we are connected with the patient, but we're sitting in our clinic and the caregiver is doing all that work that I just described as sort of almost like a therapist extender model on the other end. So the caregiver is walking around the home holding, in this instance, it was actually often a laptop, smartphone, like some other portable computing device under the supervision or direction of the clinician on the other end who's trying to complete that checklist. So on our side, on the clinical side, our observation is limited by the video interface. Obviously, we can't smell, we often can't see very well. So we're having to ask lots of questions of the caregiver in order to kind of clarify what we're looking at. In terms of measurements, we can't take measurements sitting 20 or 30 miles away. So either the caregiver has to take measurements during the session if we needed those, or we ask him or her to take them outside of the visit. So thinking about sort of all of those ramifications for, again, a pretty complex evaluation process. And so what we were looking for, the primary outcomes for this project were related to feasibility. What can we do? What can we see? And then acceptability. How does this evaluation, how acceptable is this to caregivers? And so what we found was that over half of our participants use their own device. And so that's something to sort of think about if you're ever considering a telehealth project with a family, is if you give them a device, which often research teams do, then there may be a learning curve with them learning how to use it, as opposed to if you allow them to use their own, that they be more comfortable using their own device. We had, perhaps not surprisingly, frequent tech issues, the most common of which were blurriness or pixelation. Because again, think about, you're asking someone to hold a laptop or a tablet to pan and show you the environment. So as you can imagine, many people kind of did that really quickly. They sort of didn't know, they kind of went by and skipped certain areas of the home. And so and not surprisingly, we also had audio cut out a lot. We had some freezing. We had communicating, we were talking over each other. So those were sort of the most common kinds of technological issues. But we had to do a ton of coaching and cueing, like constantly sort of directing and helping and guiding people as to the process. Like, could you move closer to that? Or asking them to clarify. Like at one point I was looking and we couldn't tell what an object was in the corner of the room. So we're like, is that a fireplace? Like, what could you move closer to that? And so there was a lot of kind of constant collaboration with the caregiver. Caregivers often they were operating the technology in their own, but we did have instances where caregivers had needed a helper. In some instances, it was because someone was taking a measurement and someone else in the home was operating the camera. So there were instances where we had a couple of people helping. And then we didn't have adverse events, thankfully, but there were sort of some interesting safety concerns. So one person at the end said, I'm really exhausted. And so we realized we were so focused on getting our evaluation data that we really weren't able to visualize her or to see what her own level of fatigue was. So that reminded us that we need to be checking in with people verbally if we're doing a sort of visual kind of assessment. We also had at one point a caregiver tilt the device down and we noted she was wearing bare feet, which in this instance was fine. She was in a sort of senior living apartment. We didn't ask her to go outside, but if we had asked her to go outside and sort of help us to assess the entrance to the home, obviously that would have been unsafe. At one point, we also had a caregiver who thought her husband was in one room, and then she realized he wasn't. So she put the camera down and said, like, I lost my husband because he had wandered. So all of this kind of raised some interesting considerations, which I'll talk about in a moment. And then in terms of satisfaction, we had people fill out like a 9-item checklist. How well could you see? How well could you hear? Was this an efficient use of your time? And so we basically found that 80% rated less than strong agreement on one or more items. And a lot of times those lower ratings were very much connected to the technology lapses or failures. So for example, when one family had the screen froze on their end, I could still see, but they had trouble seeing us. And that really just kind of was disorienting and confusing for them on the other side. Another family, it took over an hour for them to just get logged in. And so obviously that was not an efficient use of their time in terms of that item on the scale. And then lastly, we had thinking about the presence of the person with dementia, we had a family where the person with dementia was sort of, I guess, shadowing, for lack of a better word. She just didn't really understand what was going on, why we were there, what they were doing. And so it was clear the family was almost trying to kind of get through it quickly and kind of rushing through the process because it was just very kind of disruptive or disorienting to the person with dementia who was just having trouble understanding what was going on. So taken together, we just kind of came up with kind of a list of tips and tricks, I guess, for video telehealth, some of which is really helpful, I think, in the context of any patient population. Things like trying to minimize glitches, trying to get a sense of their baseline technological competence to know, like, how often do they go online? What is their level of comfort with technology? Making eye contact, all of those sort of general kind of Zoom principles. But then some are sort of more dementia focused, like, again, making sure that the person with dementia is safe if you're going to be collaborating mostly with the caregiver. In this, there might be a role for sort of a home health aide if you have someone on the other end who's a paid caregiver, maybe, who could help and just sort of be with the person with dementia while you're doing your evaluation. Also thinking about the timing of the visit. Again, we did a late afternoon right before dinner, that appointment that I mentioned where the caregiver, the person with dementia rather, was somewhat confused. So that was kind of probably a poor time of day to try to do a visit with her. So thinking maybe earlier in the day may have been better. So thinking through those kinds of implications, I think, can be helpful as well. And then I'm going to shift. So I'm going to stop sharing my screen. Make sure I'm back while I introduce Dr. O'Connor as I shift over to Dr. O'Connor, who's going to get herself set up while she's getting her slides shared. I'm going to just let you know. So Dr. O'Connor is a board certified neuropsychologist. She earned her doctorate in clinical psychology from Indiana University of Pennsylvania in Indiana and completed an internship in neuropsychology at the Yale University School of Medicine in New Haven. Her postdoctoral training was completed at Weill Cornell Medical College, Memorial Sloan Kettering Cancer Center in New York, and the Bedford VA Medical Center in Boston University School of Medicine in Boston. Dr. O'Connor is currently the Director of Neuropsychology at our Bedford VA Hospital, Assistant Professor of Neurology at Boston University, and leader of the Research Education Training Program at the BU Alzheimer's Disease Research Center. She has served on the boards of the Massachusetts Neuropsychological Society and National Academy of Neuropsychology. She's currently a member of the National Academy of Neuropsychology Brain Health Task Force and a board member of the National Academy of Neuropsychology Foundation. Dr. O'Connor specializes in the clinical evaluation and treatment of older adults, having developed the Bedford VA's Memory Diagnostic Clinic and the New England Dementia Caregiver Suite of Services. Her research interests focus on understanding cognitive aging and the development of interventions to help aging adults and their families. She currently receives grant funding from the Alzheimer's Association, NIH, NIA, and the VA Rehabilitation Research and Development Service. And I turn it over to Dr. O'Connor.
Thank you so much, Dr. Gately, for that introduction. And thank you, everyone, for inviting me here and listening to what I have to share with you today. So I'm going to focus on telehealth for dementia caregiver services. Within our neuropsychology service, we have a number of telehealth initiatives, but for the purposes of this talk, I'm going to focus on a few programs that have taught us some valuable lessons about the use of telehealth for older adults with dementia and specifically for their caregivers. I'll focus on our teleneuropsychology clinic and 2 of our telecaregiver group interventions. So I'm going to talk about each of these things with a focus on lessons learned and then try to pull it together with some takeaways. And I have some publications of ours referenced there for you if you'd like to take a look at those. So again, just in terms of sort of orienting us to a little bit to where I hope to bring us today, I'm going to start with sort of a broad lessons about acceptability for of telehealth services for older adult patients and their family members by highlighting our teleneuropsychology clinic. Then I'd like to shift our attention to dementia caregivers and telehealth with really just a quick overarching lesson learned from some interviews that we conducted during COVID-19. And then focus on telehealth interventions specifically for dementia caregivers and the lessons that we learned from 2 of our internal initiatives. And again, at the end, I plan to try to wrap all of that up into some key takeaways. I'll just mention before we get started as a quick note that all of the clinical initiatives I'll present on utilized slightly different telehealth platforms and formats, and I'll briefly highlight that as I present. The hope, of course, is that you'll hear some things that you'll be able to take with you into your own work. So beginning with our teleneuropsychology clinic, this is a clinic that our team here, our neuropsychology service, really spearheaded by my colleague, Dr. Melissa Kraft, established in 2017, so pre-COVID, to allow us to conduct diagnostic evaluations of suspected dementia for our older veterans living in rural areas that had barriers to accessing specialty care at the main hospital. The platform here was video to our community-based outpatient clinic, so not video to the home, as Dr. Gately was just talking about. Our community-based outpatient clinics are local clinics in the community where veterans can travel to receive care, but which are much closer to their home than having to travel to our main hospital campus. So for these particular visits, a technician at the community clinic would greet the patient, set them up in front of a video monitor, and also, when needed, they would act as the neuropsychologist's hands to display specific test stimuli for our tests of memory and thinking. The neuropsychologist would be remotely located at the main hospital, and provider referrals to this clinic grew very quickly from the start in 2017. Doubling in size from the first 6 months that it opened compared to the 6 months right before the pandemic. And we were specifically interested in excluding pandemic data from the eventual manuscript on this work, because we really wanted to capture what was happening at a time before people had to engage in telehealth services. As Dr. Gately mentioned, there was this sort of a large upswing in telehealth due to COVID. So the increase in referrals that we received over time suggested to us that providers found telehealth an acceptable way to obtain a neuropsychological evaluation. We also found that very few veterans and their family members that were contacted for a visit declined, telling us that patients and families also found this to be an acceptable way to obtain a neuropsychological evaluation. When we compared our in-person memory clinic sample with our teleneuropsychology memory clinic sample, we found no difference in age, education, and gender, but the teleneuropsychology group did have a higher area deprivation index score. If you're not familiar with this, this is a measure of neighborhood socioeconomic disadvantage created by Dr. Amy Kine and colleagues at the University of Wisconsin. It's a publicly available tool, so you can Google that tool if you'd like to take a closer look. The veterans in this clinic were mostly rural veterans in New England from these disadvantaged neighborhoods. And when we looked at the distance of travel saved for these individuals, what we found was that if they had had to travel to their nearest hospital, they would have had to travel about 60 miles to get to that major hospital for a neuropsychological evaluation. But they only had to travel about 17 to their nearest community clinic. And that was roughly equivalent to the distance our outpatients from the communities surrounding the major hospital had to travel for their in-person evaluations. So using this telehealth platform, we were able to level the playing field, so to speak, at least for distance traveled, by offering these teleneuropsychology services. We also found that teleneuropsychology patients reported high visit satisfaction. They felt the travel was easy and stress-free. Dr. Gately talked a little bit about this visit related time and travel, the helpfulness of going to a familiar clinic where they received their routine care. Importantly, they also reported that they were able to build rapport with the clinician. They felt comfortable sharing personal information and felt that the clinician cared about them despite the different virtual format. And these ratings were equivalent to our in-person memory clinic patients. So the lessons that we learned here were that individuals with cognitive concerns and their caregivers were willing to engage in telehealth visits. Our recruitment relied on partnering with rural providers. Providing the option for telehealth reduced travel burden for these individuals who would have had to travel about 3 times further if they had to go to the main hospital. We were able to target the individuals that we wanted to, people that had barriers to in-person care, so rural, socioeconomically disadvantaged veterans, those most vulnerable to travel-related expenses, things like the cost of gas, taking time off work, et cetera. And the subjective experience was positive, with high visit satisfaction and a good felt relationship with the provider, no different to in-person. Also, I think, again, importantly, this was not during COVID, so people were choosing to engage this way. They didn't have to engage this way. Now, moving just very briefly to some interviews we conducted with a small sample of dementia caregivers living in New York City at the time of the pandemic, which many of you probably recall was an early epicenter of the pandemic. This work was done with my wonderful team at BU and NYU. I'll refer you to the publication for those individual names. And this was in the context of a larger study that we're doing on couples navigating dementia. So we were conducting these interviews to try to learn a little bit more about what was going on with family caregivers during COVID-19. Our sample here was quite homogeneous, which is an acknowledged limitation. So these were mostly female, white, heterosexual caregivers. And that said, we did hear some of the similar sorts of things that other researchers during this time heard, primarily related to the loss of level of support caused by the pandemic and changes in their relationship with the person with dementia. But what I want to focus on here, and this is simply, one minor and broad telehealth lesson, is that all of the caregivers that we interviewed talked about the importance of telehealth during this period of time. The importance of telehealth allowing them to connect with providers and programs that they had lost support from, but also the importance of telehealth allowing them to connect with family and friends. So the lesson here being that dementia caregivers were telling us that telehealth was a viable and valuable way that they could be supported. So now I'll narrow our focus further and talk about 2 of our telehealth synchronous video-based dementia caregiver interventions and some lessons that we learned specific to these dementia caregiver interventions. And again, the focus here isn't on the intervention itself, but on the lessons learned in terms of telehealth implementation. So the first intervention we'll look at is called Telecare. This was a telehealth adaptation of an in-person intervention called CARE that aimed to teach caregivers ways that they could manage neuropsychiatric symptoms. And this was a group intervention, so there were multiple caregivers on a video platform to the home. The work was funded by the Alzheimer's Association, so just a shout out to them, and it was funded before the pandemic, but it was conducted during the pandemic. Also, I just want to acknowledge that I had a great team at Bedford doing this work with me. Their names are represented on this slide. The caregivers in this sample were mostly female spouses. They were all white. They were all living with the person with dementia with primarily a greater than high school degree. So again, we need to acknowledge the homogeneity here. They were an older sample compared to the next intervention that I'll discuss, with an average age of 72. And most of them reported providing almost constant care, which I think is typical for our dementia caregivers. They reported that the person with dementia had at least one neuropsychiatric symptom. And then they engaged in the 7-week, 1 hour a week program. The platform again here is video to the home, with WebEx being the specific technology that was used. And what we found here was that 70% of these individuals had some difficulty using the telehealth technology. Things like turning the power on to the device that they were provided with. So these folks were provided with a tablet to use for engaging in the intervention. And Dr. Gately mentioned the sort of learning curve that might need to happen when people are given the device versus, using their own device. So I think that could be a consideration here. Also things like helping them to access their email and figuring out where to click on the video conferencing link. Issues related to password retrieval or reset, which I can empathize with. Instruction about how to turn on the camera, how to mute and unmute themselves, how to use the raise hand feature. We had one member with absolutely no experience at all with technology, so they needed very basic instruction related to just orienting themselves to the device, turning on the device, setting up an email, orienting to the general screen and keyboard, etc. And we came to quickly appreciate that we really needed a designated person on study staff to offer technology assistance. We also found that with personalized support, caregivers needed less support with each passing session. So they were able to learn to use the technology over time. And at immediate follow-up, they all reported feeling a sense of accomplishment related to technology use and increased comfort with technology. That said, we found that at 3-month follow-up data collection, there was again an increased need for assistance as their skills decayed from the last time they had used the technology 3 months prior. And here's a nice graphic illustrating that information with decreased assistance across the 8 sessions, which is the 7 study sessions plus the immediate data collection using the telehealth platform. But then we see this bump up in assistance needed after 3 months of no use, but not all the way up to where they were the first session. So that's good. So the lessons that we learned here, many of these older adult caregivers had difficulty using technology to engage in telehealth, but they were eager and able to learn to use the technology and engage when they received personalized help. And with repetition and practice in the context of this specialized and sort of continuous personalized support, their skills improved to independence for almost the majority of people that we worked with. Those skills then decayed when they weren't using them regularly, requiring some additional support. Moving on to our second dementia caregiver intervention, this was a clinical intervention outside the context of research, with data collection as part of quality improvement efforts. These efforts were led by my then postdoc, now colleague, Dr. Zoe Bell, and a team of other neuropsychology trainees who are featured on this slide. So acknowledgements to their hard work, and hopefully our manuscript detailing this work will be coming out soon. The intervention here is 10-week intervention that's run for an hour a week. It's also group-based over video to the home. And here the sample was only about 60% spouses compared to 80% for the prior telecare group. And the average age was younger with a range of 40 to 77 years old versus the prior group at 59 to 84 years old. Caregivers in this intervention reported being highly satisfied at the conclusion of the intervention. So for this program, without funding for dedicated technology support in this clinical setting, the lead clinician conducted individual orientation with each participant to the technology prior to the first session. We also mailed each participant a physical manual so that they would have something that they could follow along with. And then we would share slides on the screen that corresponded to the manual to help participants follow the flow. Even still, we realized quickly that we needed to send a user guide for the VVC platform. That was our video platform here, due to some problems that people were having with the platform. So we did send that through the mail and incorporate that into our mailings for each successive group as we moved forward. We also realized that we needed to add a telehealth etiquette section to the manual. Things like how to use the raise hand feature to minimize interrupting, making sure that people understood that they, should have their face visible in the camera and consider the lighting that they were in so there weren't shadows on the face. Making sure that they were muted and that they were someplace where there was little or no background noise. We asked people to consider wearing headphones if there was hearing impairment or privacy concerns. And speaking of privacy, we included things like finding a private place to engage in the intervention. For the first group of intervention participants, there could be the person with dementia walking around in the background, or interruption from young children or pets. And so this was something that by experience, we felt we needed to include in this telehealth etiquette section. We also asked people to remain stationary as much as possible, find a comfortable seated or standing position before the intervention started, because some people were taking their device and walking around with it, which was distracting to other group members. And finally, to consider attire, that you may not want to come to the group in your robe or without a shirt on, and sort of thinking through some of these things, even if you're in your own home. So we found that 86% of this group felt the technology was easy to navigate. That's curious compared to our other group. It may be, as I said, that these folks were a little bit younger. They sort of fell outside that 80+ older age band that Dr. Gately referred to. They were also on their own devices, so that may be another consideration in terms of ease of navigating the technology. But still, other participants needed help. There were also 2 caregivers that wanted to enroll but couldn't because they weren't equipped for telehealth. They lacked access to reliable internet. And there was one caregiver who enrolled but was never able to successfully connect via video. And they attended every session by phone, but ultimately we excluded them from the final analysis because their outcomes were so much different, so much worse than the people that had joined via video. So there may be these sort of differences in intervention success depending on how people are engaged. And, we don't know how many people didn't even bother expressing interest in the intervention because they either anticipated that they would have challenges with technology, or they were concerned that they would have challenges with technology, or they didn't feel like they wanted to engage in that way. So here, the lessons learned were that caregivers are, again, willing to engage in telehealth interventions, but that this might not be easy for all caregivers. So there are these issues related to digital inequity and digital health literacy that need to be addressed. I think both of these intervention experiences underscored the need for support. Again, our teleneuropsychology clinic setup is quite different with people that are there to help participants, patients, families navigate the technology and interact with the technology. But with our interventions that are video to the home, those folks did need support. And that can be more difficult for clinical interventions that lack funding to hire a specific person to provide that support. We did find that it was helpful to provide support and instructions via handouts that we mailed to people, and that we needed to adapt our intervention to include this telehealth etiquette that I talked about. So there are 7 key takeaways, or 7 things that I think are key takeaways, and there may be others that I'm missing here. But older adults, including those with cognitive concerns and their caregivers, want to engage in telehealth. They're willing to engage in telehealth. That telehealth has value for reducing these barriers to in-person care, particularly for underserved populations, but not only for underserved populations. And I think Dr. Gately presented some really nice slides about the burden of going to in-person visits for dementia caregivers that are not just related to travel time. Satisfaction with telehealth can be high and maybe no different compared to in-person services, at least for some of the metrics that we gathered. Digital inequity needs to be addressed as a public health issue. Digital literacy also needs to be addressed. Older adults need access to specialized, continuous technology support. Not all of them, but many of them, and maybe many of them, particularly in that sort of older 80+ band. But dementia caregivers can learn and reach independence using this technology with these personalized supports. And we believe that it's helpful to adapt these services by thinking about doing things like mailing out manuals or providing physical materials, using slides on a screen to help people further engage with materials, and including some information about telehealth etiquette. So thank you so much for listening to our talks. I think at this point, I see that Dr. Gately has come back, and we're happy to try to field any questions that folks might have. Dr. Gately, do you see a Q&A area?
I don't see anything yet, but folks, I don't know if people are able to unmic or if they're welcome to put any thoughts or questions, or of course, Dr. Frogner, Dr. Specs, feel free to chime in any questions or thoughts. Thank you so much, Maureen.
This is Bianca. Thank you so much for that great presentation. It was so interesting, Megan, as you set us up to understand kind of what's taking place when you visit homes, and then Maureen, for you to describe kind of how some of the patients kind of accept this. So I just taking a step back, care is certainly delivered across multiple environments. So people's individual homes versus adult family homes and other assisted living facilities, or even nursing homes. So I know, Maureen, you talked a lot about outpatient places where people can go within the community, but could you speak a little bit, I know maybe it takes it's taking a step back from some of the work that you presented, but how is the modality of using telehealth varying by those different settings? Like, what are some challenges that you see in terms of adapting these technologies to work across these different places where we know people get care?
Yeah, that's a good question. So I can sort of take a stab at answering that. I think that some of this is service dependent. So, for example, for our teleneuropsychology clinic, during that clinic was established pre-pandemic. During the pandemic, when patients were not able to go to their community clinics, we switched very quickly to offering teleneuropsychology to the home so that we were still able to offer these services. And for that particular service, that simply did not work. There were, we could make an approximation to the evaluation that we wanted, but we came to appreciate that, that simply wasn't a good format for that service. So I think that sometimes these services need to be provided to places in which there is additional support and structure. And, that may also have implications for the setting in which they can be provided across the sort of continuum of these various care settings.
And I'll just chime in. I don't know. Let me know if you all are having trouble hearing me. I'm getting these flashes of unstable network connection, but I'll just sort of add on to that. I think that, there were some, the COVID just presented such an interesting sort of natural experiment, and that there were really innovative models that were explored during COVID that I really think actually would be beneficial in a post-COVID landscape. Like, for example, we all heard about sort of video into nursing home settings where you would on that instance have a paid staff member most likely helping with the technology on the patient side, and that was in a bit able to, families weren't allowed to go in. I feel like that's a really nice model which we should continue to explore to connect, even if it's interprofessional clinicians or if it's, again, additional family members who may live in different states. And I'm not sure actually the extent to which we're still doing that. And I also am thinking, because now we're trying to shift care into the home, how can we partner with paid caregivers, home health aides, or others who may be there? Because a lot of people, I think, increasingly are living home alone, maybe not necessarily those with dementia, but some people with dementia are living at home alone, sometimes at least in the early stages. So I think that as we move through the care continuum, we have to sort of think about how can we get creative in terms of involving other people. And again, COVID was such a nice is a bad word, but it was such an interesting experiment that, again, it pushed us to explore these different ways of delivering services. But I think, I do worry, I guess, a little bit about kind of a sort of reversion back to the mean, I guess, where we kind of don't think about access issues in the same way that we thought about them then. But as Dr. O'Connor is saying, a lot of our families face access challenges, period. I mean, going into the medical center, even if you live 5 miles away, for someone who has a dementia diagnosis, is a challenge. So it doesn't matter, as Dr. O'Connor was saying, about distance. It's as much about just the sort of the challenges related to coming in. Looks like we do have a question from Beth Denoff. Thank you. I'm wondering if telehealth home visits will increase by the Guide Dementia Program providers. What are our thoughts? Yes, and actually, I'm not aware, Maureen, I don't know if you know if there are any VA systems yet implementing Guide. I know, of course, Guide is, of course, extremely important right now. I'm not exactly sure. I don't know if you're aware of any settings implementing it.
Yeah, no, I'm not. I am not aware of any VA settings that are that are implementing the Guide program. But I do think that telehealth home visits could be a useful part of Guide. I can't speak to that directly. I'm not aware of anybody using telehealth within that initiative.
Yeah, I agree, especially since to me, the thrust of that program is sort of how do we increase both kind of the interprofessional, how do we mobilize interprofessional care teams to work with people with dementia, knowing that it takes a village to support a person with dementia and their family, but also how do we provide ongoing support? I mean, that's been so much evidence that we need to not just have this upfront evaluation, then we send people on their way and say good luck. Like, we need to be checking in with them periodically throughout, taking almost like an early intervention model, right, where we kind of provide a lot of supports, but then we know things are going to change for them. So I don't know if it would occur to me, since I know that the award network is so prioritizes sort of looking at addressing workforce enhancement issues. I don't know, Maureen, if you have a thought about how we're able to use telehealth to address some of the workforce challenges that exist throughout dementia, but also I think other kinds of specialty care services.
Yeah, I mean, I think that what we've seen is that there are, a number of hospitals, areas in which, the types of services that we offer don't exist. And instead of simply not having those services available, we're able to partner with those healthcare providers to offer them services via telehealth. So, so that's been really nice to be able to connect with and offer services really for some of our programs to a national landscape of, patients and families. So I think, that can help with the shortage of healthcare staff in these areas. It is a little bit of a puzzle, right? Because the more referrals that we get, then the more we need more staff to be able to provide those services. But I do think it's one way that we can sort of effectively stretch our services to reach people who are in need that maybe don't have healthcare providers in their immediate area.
Yeah, and I know for us, like a lot of specialty care, I mean, OT tends to be situated in urban medical centers. Like there are we don't have as
Absolutely.
many community-based providers, so I know it's a way for us to sort of leverage the and of course people who identify as having a dementia expertise are even fewer and further between. So it is a way to kind of increase. I think it has the capacity at least to address some of the workforce issues. And we're getting towards the
Well,
top of the
yeah.
hour, but yeah.
This has been great. I really appreciate this conversation, and certainly, hopefully, people can reach out to both of you if they have any additional questions. And this will be posted
Absolutely.
online since it has been recorded. So I'm sure folks will continue to watch this over time. And as Megan, as you pointed out at the beginning, I mentioned too, as I'm having technical difficulties with my video, that's why I'm not on right now. And we're all experiencing these like little blips, slowness in the video. And it's just a reminder of just how even those of us who do this every day, all the time, we're all at the whims of technology that are completely out of our control. And that can be so frustrating. So just like listening to kind of some of the challenges people face, I mean, I just really comes to the fore. But I think, Maureen, the work that you shows, it's encouraging to know that people are open to using this technology and recognize that it is kind of part of our everyday life. So let's figure out how to use it to the best that we can, but figure out how we can support caregivers to do their work the best, and to support you all as clinicians is important too. So I really appreciate you both taking the time this morning to do this, or this afternoon for you all.
Well, thank you for inviting us.
Yeah, thank
Well,
you both so much.
thank you so much. And thanks for everyone participating today. And again, this will be recorded and posted on our website soon. So have a great day, everybody.
Okay, bye all.
Thanks so much.
Bye.
Bye-bye.